Okay, thank you very much. Let's move now to our third speaker is Jon Salmanton-García from Germany. Actually, this is a polycenter study about improved clinical outcome of COVID-19 in hematologic malignancy patients receiving a fourth dose of anti-SARS-CoV-2 vaccine. This is an EPICOVIDEHA report.
Yeah, thank you very much. And thank you very much to you all for coming here today. Yeah, as she said, it's what I will present today are results from the EPICOVIDEHA registry, which is a registry for COVID-19 patients with baseline hematological malignancies. And the main reason why we started this analysis was because at the beginning of 2022, there was a discussion whether to administer or not a fourth vaccine dose in these type of patients. Just to remember, patients with hematological malignancies had an impaired immune system, and therefore the vaccines don't work exactly the same, and they are not working exactly the same as in immunocompetent patients. And basically to check how was or which were the effects of this fourth vaccine dose or a second booster in hematological malignancy patients, we took some patients from the EPICOVIDEHA registry, a total of 102. And basically they had to fulfill 4 criteria. The first one, they needed to have an active hematological malignancy during the 5 years prior to COVID-19 infection. The second one, they had to be adults. They needed a laboratory-based COVID-19 diagnosis. And last, of course, and quite basic, they needed to have received a fourth vaccine dose against SARS-CoV-2 before COVID-19 diagnosis. If we look for the baseline status or the basic characteristics of the patients, we can see how most of them were male, which is quite coherent with the rest of the analysis we have observed in our registry. Definitely, most of them, more than 90%, were adults over 50 years old. And regarding the baseline conditions beyond the malignancy, of course, we had 50% with cardiopathies and afterwards diabetes mellitus and chronic pulmonary disease. If we look now to the baseline malignancy, half of the patients had a non-Hodgkin lymphoma, afterwards plasma cell disorders, and then other relevant malignancies were chronic lymphoid leukemia, AML, and other malignancies. Regarding the last treatment immediately before COVID-19 diagnosis, we had most of the patients that were receiving immunochemotherapy or targeted therapy. And as for the status of the malignancy at COVID-19 onset, here we see similar results as in our other analysis: 60% controlled malignancy, around 40% active disease, and then a reduced number of patients with a stable malignancy. Now we can move to the severity of the infection, which is one of the interesting points of our analysis. And we can see how the mild infection was observed in half of our sample. Asymptomatic patients were around the 10%, and severe infection, which basically were patients that were admitted in the hospital, were 40%. And from that part, only a very few and very small part of the patients had to be admitted in the ICU unit. We can see here the number of patients admitted in the hospital, and also if we look for those patients that needed oxygen administration, we can see how it was half of the patients between the ones admitted in the hospital. And now we are already finishing COVID-19 treatment. No treatment was administered or was necessary in half of the patients. And between the 60% of the patients that were those that require treatment for COVID-19, we had patients with antivirals, with monoclonal antibodies, with a combination of antivirals and monoclonal antibodies, and also a part of them that received only corticosteroids. And finally, which is the main point of the whole research, the mortality. Well, we observe a mortality around the 5%. From 102 patients, that would be 4, 5 patients, so it's actually more close to 6. So with that, we can come to the conclusions. The first one is that first, Of course, any conclusions from here have to be taken with caution because it's a descriptive analysis, but we can see how the mortality was drastically reduced as compared to previous results from, from hematological malignancy patients with COVID-19. And therefore, we may think, or actually you may think, because I'm not a physician, that a second booster is a good option for patients with hematological malignancy. And finally, in case you want to read the full details of this publication, feel free to scan the code and you will reach the publication. Thank you very much.
Thank you very much. Yes, the first question.
Thank you. Very interesting presentation.
Thank you.
Elaborate a little bit on why patients with hematologic malignancies were not treated and they developed COVID.
Actually, there are two main reasons. The first one is that they were that severely ill that the treating physician or the treating team considered that it was necessary because the patient was in palliative care. And the second option was that the patient were not really needing it from the perspective that they were not that severe to receive a treatment. Of course, if we if we focus more in detail patient to patient, there might be more elaborated reasons. But basically, the two main reasons are these ones. First, that the patient was that severely ill that the treating team decided not to give the treatment because it was in palliative care. And the second one, because the patient didn't really need the
The mortality rescued or it's not treated in palliative care? Or
sorry?
The mortality.
Actually, we didn't compare or we didn't check specifically for that. It's for the whole sample. But yeah, the patients with the mortality were those that were more severe. Yeah.
Yeah, thank you. I think this is, compared to our cohort, probably more on the spectrum of moderate to severe COVID-19. How many patients with the no treatment had mild COVID-19 or then progressed to moderate to severe COVID-19?
Yeah, we didn't see for those data either, but nevertheless, we can speak afterwards and I could check for the specific details and we could stay in contact and I could give you some, those data. Yeah, we did all the data. Basically it was a letter, so we could not really give like a very long extension or a very extensive explanation. But yeah, definitely, I have the data, so I'm doing the analysis, so I can give you that information. Thank you.
Yes. One last, yes.
Concerning antivirals, did some longer courses, for example, 10 days of Paxlovid, 2 days, or did you associate sometimes remdesivir plus Paxlovid?
Yeah, the data are coming from EPICOVIDEHA, which is a registry collecting retrospective data. So we are not really taking any decision on how is the treatment of the patients. In the case of Paxlovid, we have seen that most of the people, and actually we have an oral presentation on Paxlovid. I can tell you later when, sorry. But it will be in Hall J. So, and it's on, I think it's Tuesday at 8:30. So we will have all the details. But actually, yeah, depending on the treating team, it might be different, but we could see that most of them, they were giving actually 4 days for Paxlovid instead of 5, which is the recommended dose. And yeah, so basically really answering your question really specifically, it really depends physician to physician because it was everything retrospective and we just collected the clinical data once the patient was already lost to follow up, so to say.
Okay, thank you very much.